And without further ado, North Carolina Community College Oncology Lectures, Palliative Care and Hospice for the Cancer Patient with Gary Winzelberg, MD, MPH, and Jenny Hanspal, RN, BSN, MS, and OCN. And here, our first poll everywhere question: people with cancer do not benefit from palliative care. And I will say we kind of try to make these softball questions. So I'm going to guess that most of you, or if not all of you, will get this right. But if you think people with cancer do not benefit from palliative care, I think that's true, A. If you think that's false, B. And we'll let you take care of that in just a minute. Gary Winzelberg, MD, MPH, directs the UNC Cancer Hospital's Palliative Medicine Fellowship Program, which has trained 13 physicians during its first 5 years of existence. Dr. Winzelberg is board certified in both hospice and palliative care medicine and geriatric medicine. His teaching focuses on improving communication between physicians, seriously ill patients, and their families. Dr. Winzelberg, welcome.
Thank you.
And maybe you can take just a minute to tell our audience, and this is mostly community college students, what was your career trajectory? How did you get from, at what point did you say, hey, I might want to be in healthcare, I might want to be in oncology, and what were the steps that led you to where you are now?
I appreciate the chance to share. So I am the first person in my family to become a physician. And for me, it was actually during college where I had the opportunity to work in nursing homes. And I saw the significant needs in nursing homes for improving care of those who live there. And so that ultimately led me to become a physician in geriatrics and subsequently in the field of palliative medicine, which Jenny and I will be talking about today.
Great, thank you so much. And let me ask one other question. I see there's not only an MD after your name, but there's actually also an MPH. And we see that a fair amount in Chapel Hill at Lineberger. Why add the MPH to the MD?
So a Master's of Public Health is, and certainly individuals who aren't doctors can have it. It thinks not just about individual patients, but learning, training that affects the public in general. And so the training that someone has in that master's, which is after someone's completed college, gets into learning about disease issues on a population level, whether it's the environment, whether it's how to think about science and how studies are designed, but it's essentially going beyond individual patient-by-patient care and thinking more broadly about what, as a society, a state, a country, do we need to provide the best quality care for individuals.
Thank you for that explanation. And for students thinking about careers, we do have phenomenal medicine programs in North Carolina and also phenomenal public health programs in the state as well. All right, Jenny Hanspal, nurse coordinator with outpatient oncology palliative care service at the NC Cancer Hospital. In this role, Jenny assists her primary team in helping patients manage and cope with long-term physical and emotional side effects and symptoms related to cancer and its treatment. Additionally, she assists in evaluating and coordinating barriers to and transitions in care amongst oncology patients and their families. Jenny, welcome, and let me ask you the same question that I asked Gary. What was your career trajectory? What led you to an interest in healthcare and ultimately to oncology?
Well, thank you. It's an honor to be here today talking about the benefits of palliative care. So nursing is a second career track for me. I started out my career as a certified recreation therapist with a master's in science in recreation administration from UNC Chapel Hill several years ago, probably more than 15 years ago. And although I really loved working with folks with disabilities, physical and emotional and mental disabilities, mostly in the community setting, I felt like there was something lacking with the clinical side of things. So I took a break for a couple of years to have a family and then went back to get a degree in nursing and started out immediately knowing that I wanted to do oncology nursing. and then got a special certification, which at the end of my name says OCN. And that is a special certification and training and large exam that you have to take to certify and vet your knowledge and skills in oncology nursing care. So I did that for about 5 years, and then there was an opportunity that came up in palliative medicine in the UNC Department of Palliative Medicine for a nurse coordinator, and I thought this is a perfect match for me because it really does blend the art and science of nursing, the emotional and the coping support that we can offer families, and talking about multiple things that we're going to be talking about today.
Great, great. And of course, we have phenomenal nursing programs as well across the state of North Carolina. Well, so glad to have you both here. We've already got folks answering that question. About 15% are saying, yeah, people with cancer do not benefit from palliative care. And then about 85%, no, I think we need that palliative care. What answer were you looking for here?
That people with cancer absolutely benefit from palliative care, and I hope to, and Jenny and I believe, will sort of make the case for those who may be doubters or haven't been exposed to what palliative care provides.
All right. Well, we are all ears. We're looking forward to palliative care and hospice for the patient with cancer. And I'll turn it over to the two of you. Just let me know when you're ready to advance those slides.
Okay. Thank you, Tim. And let me just say, I'm going to be sort of guiding the first initial slides, and then Jenny's going to be contributing. And I'm so glad that she and I are doing this presentation together, because truly one of the things that I would emphasize is in healthcare, but certainly in caring for seriously ill patients through hospice, through palliative care, it only works well when there's a team. And I could not do any of my work effectively and with the kind of quality that I'm seeking without Jenny's support and expertise, as well as other team members that we have, which actually include a pharmacist, which include administrative support, nurse practitioner. So I wanted to sort of put it out there as at the outset. The premise that I think sort of shapes our discussion today is that really over the past 50 years, and that's not a lot of time in healthcare, the fields of hospice and palliative care have had a significant impact on improving quality of life and care for patients with cancer. And that's really what we're going to focus on. Next slide, please. So the outline that Jenny and I will discuss is one of a bit of history, which I think is important in terms of how did we get these fields created and growing, then drill down on what the important clinical components are of hospice and palliative care, and to make clear how they're related and how they're different. And specifically from the patient and family perspective, what are they experiencing with both types of services? And then finally, some data about what we know in terms of outcomes of hospice and palliative care for patients. Next slide, please. So again, quick evolution of where we are with life expectancy and even causes of death. So, 120 years ago at the turn of the last century, life expectancy was almost 50 years old, and people died of infection, which certainly is in the news today with our pandemic, but that was the norm. Pneumonia, influenza, tuberculosis, because of unclean water, gastrointestinal infections. But what changed over 110 years is life expectancy changing, increase, but that the causes of death weren't acute, but became chronic. Heart disease, we're going to focus on cancer, lung disease related to smoking, and what I would even say, though dementia is not one of the top 3 causes, it's part of the mix. It's underrepresented as a cause of death. Next slide. And so some of those factors are certainly public health, sanitation, water, vaccinations, and I certainly hope we'll have a COVID vaccine as soon as possible. And then disease-directed treatments, whether antibiotics, treatments for heart disease, and then cancer treatments, which really began 50 plus years ago, initially with chemotherapy, radiation therapy, and then more recently, you may have heard of immunotherapy. Next slide. And so what really has changed in our culture is that dying itself has become a chronic condition, that the decline that people experience in their bodies, even their minds, don't happen quickly. They happen really over months and sometimes years, and that part of that chronicity over time is the availability of life-prolonging interventions, which can create challenges with decision-making, use of the intensive care unit, breathing machines, kidney dialysis, and as well, it not just affects the patient, but the families are in the role of caregivers, that patients and families have significant financial impacts, or what some describe as financial toxicities. Next slide. And so one person who's really credited with changing the culture even internationally is a doctor, but not just a doctor. She was sort of her own team in one person. She had nursing background, social work, physician. Her name was Cicely Saundersido, and she lived in Great Britain, died 15 years ago. And she founded the first hospice really in the world, as I understand it, St. Christopher's in London. And the first patient there was admitted 53 years ago. So thinking about where medicine was from 1900 even to 1967, hospice care only started then. Next slide. And so I just wanted to quote from her, and this is from 10 years before she started the first hospice. It appears that many patients feel deserted by their doctors at the end. Ideally, the doctor should remain at the center of a team who work together to relieve where they cannot heal, to keep the patient's own struggle within his or her compass, and to bring hope and consolation to the end. And I think what she focused on is, what could we do to help people live even as they're struggling, even as they're dying? And she identified hospice, as we'll talk about, a different kind of care as important to supporting that and keeping physicians involved. Next slide. So I think this may be the last sort of history slide, but just to sort of give you all a sense, taking it into, a little bit into this country, Medicare and Medicaid, which are the predominant sort of health insurance for people over 65, with people who have limited financial means, started in 1965. A woman named Kubler-Ross wrote a book about death and dying a few years later. Kidney dialysis became a disease itself that received coverage in 1972. The first hospice in this country was a few years later in Connecticut. Hospice itself became a benefit in Medicare and then in other insurances only in 1982. So it's really only been around for less than 40 years. Next slide. So this gives you a sense. I said hospice as a benefit started in the 1980s. This takes you from 1992, when only about 200,000 patients received hospice, to 2014, where over 1.5 million individuals received hospice care. And if you can see on this slide, the sort of bottom bar, which is orange in my vantage point, is cancer. So cancer remains the most common diagnosis for which people receive hospice services, and the numbers are steadily growing as our population ages. Next slide. So before I talk more specifically, the question is, hospice care provides all of the following services except. So if you could answer that.
And again, this is completely anonymous, so if you're not sure, that's fine. Take a risk. See which one of these you think is not provided through hospice care. And if you'll take about another 5 or 10 seconds, really appreciate all the responses that are coming in. Right. Well, we've got great participation here, Dr. Winzelberg, and three different answers that our audience went with. Which one are you looking for here?
So the answer, which I'll share in future slides, is D. That is not something that's provided by hospice care, and I'll share the rationale.
Great. Thanks for all those responses.
Absolutely. Next slide. So the philosophy of hospice is that those individuals and their families that are essentially facing death because of life-limiting illness and the associated grief experience the best care that we as humans can offer. And it really, to this day, is the model of quality, compassionate care at the end of life. As I mentioned at the outset, it requires a team that provides expert medical and health care, pain and symptom management, and then support, both emotional and spiritual, that are tailored to the individual patient's and family's needs. And that team includes nursing, that I would say really is at the apex, medicine, social work, chaplains, volunteers. And the goal, as I sort of boil it down when I talk to patients and families, is to help support each day to become the best day possible, independent of the number of days. Next slide. So to get into some of the nitty-gritty, which can be important for Medicare eligibility, for payment of hospice, or even for other insurances, is that a physician does have to certify a patient as having a terminal condition, one that they will die from, and that they are expected to live for 6 months or less if the disease takes its normal course. Patient needs to be able to desire to pursue comfort care over disease treatment, and that's why chemotherapy is not a service that is covered. The focus is on comfort. And then, just to give you a sense, it's not as if someone is there and then, they can live for as long as possible. There's reevaluation of, are they continuing to benefit from hospice, meeting eligibility after 3 months, after another 3 months. So it's a team process that continues to evaluate the patient. Next slide. So this gives you a sense just in terms of what some of the challenges are in terms of that 6-month prognosis. Many patients and even doctors sort of shy away from. And so what I will highlight, I don't know if you can see, is there's a statement about very short enrollment. And so for patients in 2010, there were, for those living with cancer, at least 10% received hospice care even for less than a week. And if you combine hospice and other diagnoses, heart, lung disease, fully a third of patients were only in hospice for a week or less. And so there are a lot of barriers, and Jenny will talk more about some of the barriers to providing this important service for patients who are living with cancer towards the end of their lives. Next slide. So the general eligibility requirements that I would share as you're thinking about this is, one, again, people need to focus on symptoms and their quality of life rather than continuing to treat their condition. Generally, there needs to be evidence that their cancer has progressed. There needs to be evidence that they're not sort of doing well in terms of losing weight. Albumin is a measure of essentially someone's nutrition. There needs to be dependence in at least 2 what we call ADLs, or activities of daily living, so needing assistance with bathing, dressing, even feeding, needing frequent care that might be manifest in a hospitalization or going to the emergency room or needing lots of visits with their doctor. If someone has what we call pressure ulcers, where there's breakdown of their skin, that can be a sign that they're eligible for hospice. And so we focus on cancer, but I would note that there have been criteria that have been developed for other diseases as well. Next slide. And so the benefits of hospice is that team support for both the patient and family. And I'll share other situations where someone receives hospice, but the vast majority of people receiving hospice services are at home, and that's where they generally want to be. And so all of the medications, equipment, I mentioned in that Poll Everywhere question, hospital bed, supplies that are needed for that person's comfort and that relate to their terminal hospice diagnosis are covered. And that's actually different sometimes than what regular insurance will pay for. The other piece that I think is really important, and I wasn't surprised that some thought that it wasn't provided by hospice, is bereavement support. You know, we focus so much in healthcare on the patient while they're living, but those who survive have important needs as well. And so hospice is responsible to check in on family members for up to a year after the individual dies after receiving hospice care. Next slide. And so just to give you a sense in terms of home hospice services, it's not one size fits all, and Jenny will talk more about her approach to coordinating services, but there is 24-hour on-call support, and it doesn't mean 24 hours someone, you know, a nurse in someone's home, but it means talking to someone if there is a concern about how someone's doing, getting advice about how to support them. The nurse visits that may happen at home might be once a week, can be more depending on someone's need. There can be a role for home health aides who are an important member of the home hospice team and the care that they provide to assist with that person at home. Social work, chaplain, volunteers is also an important role. And actually the physicians tend to sort of step back a little bit in terms of the importance of the other team members and are served more as consultants to the primary team members. And again, I put at the end in bold, it really depends on each hospice, what services they have, and primarily what are the needs of the patient. Oh, next slide. So inpatient hospice, so most people are receiving care at home, but there are some people who have pain and symptoms that can't be managed at home. And so some hospices have their own sort of buildings where that patient can not have to be in the hospital, but can receive hospital level care primarily for symptom management. And so it requires them to have a need 24/7 that is served by hospice. It's usually meant as short term for hours or days. And hospice is very generous financially in terms of covering all of the costs related to that care. Next slide. This is an example of UNC's inpatient hospice, and throughout the state, wherever you are, hospice facilities are generally small. UNC's facility only has 10 beds, all private rooms, very intensive nursing assistant care, and is really a blessing, you know, at the end of life for people that need it in terms of the quality of care. Next slide. So just briefly, a few other services. Sometimes caregivers burn out, and so if they need a respite, their loved one can receive care even in that hospice facility for a few days, up to 5 days, so their loved ones could get a break, even take a little bit of vacation. And there's also even more intensive care that can be provided at home if necessary on a rare basis. Next slide. So some of the barriers, and Jenny will talk about others, is, you know, one, people struggle with that transition even as their condition may be worsening in terms of, is it time, does it make sense to stop chemotherapy, other cancer treatments? Doctors in particular are very challenged by making prognoses and thinking about, you know, what's the disease course, the course of cancer, that can limit engaging with hospice. If someone doesn't have sufficient caregiving at home, that can be a barrier and leads to discussions about nursing home care, other kinds of situations, because hospice does not pay for room and board in nursing homes, unfortunately. Next slide. So I just wanted to highlight one thing on this slide, which is there are significant differences, even inequities among race and ethnicity in receiving hospice care, and there are active research interventions to try to share that. And so let me just even share, for white patients, it's about, for those over 65, it's about a third of individuals receive hospice care before they die. And this is from 2017. And again, I don't know what the right number is, but presumably it shouldn't differ by race. And among African Americans, it's, only about a quarter versus a third. For Latinos, sort of similarly. And so I think that's something, again, a whole nother important topic about what differences there are and why they exist based on race and ethnicity. Next slide. So one of the things that I would recommend in terms of addressing hospice concerns is to ask about experiences that someone has had with their loved ones or friends. Very few people are neutral about hospice. People will talk about how incredible a service it was, or they'll express fears that they may have had based on a loved one's experience, and to talk about that can be important. I think what I try to do first of all is, if the goal of the person's care is their comfort and dignity, that's a reason to be thinking about hospice care. And we can recommend it to try to serve that goal. I think, to me, the focus is on living and not dying. How can we help each day be the best day possible, maximize someone's quality of life so that they can have as much time with their loved ones? I think the important thing is that we're not abandoning patients who are receiving hospice services. We're changing the focus of their care. And that, we don't have a sense, people think because there is this sort of 6-month prognosis related to hospice, that it means that they are going to die soon. We don't know. Next slide. So I've talked about hospice and where it's provided, but if you go back to 2015, if you think of, for adults, where people died, what site was the most common location of death?
All right, and again, take about 10 seconds. Thank you so much for going ahead and putting your answer in. And Dr. Winzelberg, what answer is actually the correct one here?
Well, I'm curious. You don't give folks many seconds here. I think people were still.
Sorry about that. Well, you're absolutely right. We'll wait about another 7, 8 seconds.
It looks like A and B are competing, which I think is a wonderful sort of metaphor. Which is, what studies show is most people say that when it is their time, they want to die at home. But as I'll share, I think in the next slide, which has really led to the development of palliative care as a field, most people, the highest number of patients, are still dying in the hospital. That's changing, but it's still where we are. Next slide. So this is where, from 1999 on the left side of the slide to 2015, sites of death. And if you can see, home is absolutely increasing. That's the green line. Hospital is progressively decreasing. Inpatient hospice, which really didn't exist in the year 2000, now is serving over 200,000 patients. I mean, things are changing, but there still is a disconnect between what people say they want and what they're getting. Next slide. And so what people started to ask kind of 25 years ago is, we've got this service, hospice, but there are problems. Why isn't it enough? And I just wanted to sort of highlight a really important study that was done actually when I was in training, that looked at essentially how people died in hospitals in the United States back in the 90s. And they looked at almost 10,000 patients with 9 life-threatening diagnoses, including metastatic cancer. And these individuals had a 50% chance of dying within 6 months. And what they learned about these patients' experience were a lot of them had pain. 50% had moderate to severe pain prior to their deaths, according to their families. A third of the people who died in the hospital were in the ICU, the intensive care unit, for a long time, more than 10 days. Only half of the doctors knew when their patients wanted a natural death or to have a do not resuscitate order. And they actually had an intervention that helped nurses learn what patients wanted and communicated it to doctors. It didn't have any impact. And that really shook the health world in terms of the issues that patients were having. Next slide. And so this is a busy slide, but what I wanted to focus, if you look on the left, cancer, these are patients who, well before they may be eligible for hospice, they have lots of symptoms: pain, trouble breathing, fatigue, trouble eating, constipation, emotional issues, sleep trouble, and all of those other diagnoses pretty similar. And so, if we wait for hospice to try to provide comfort for patients, we are waiting way, way too long. Next slide. And so the model before palliative care was people would get disease-directed care to try to prolong life, to cure if possible, and then very close to the end of life, sometimes hours or days, we would sort of label comfort care or try to get them involved in hospice. But we were able to change the metaphor, the paradigm. Next slide. And if you could advance it. Yep. So here's a sort of a cartoon which integrates palliative care, and we'll talk about what is in the sort of secret sauce of palliative care with disease-directed treatments, cancer-directed treatments. Oh, thank you. And so what I would say as a whole is palliative care is specialized medical care for people with serious illness, including cancer. It focuses on improving quality of life really at any age or diagnosis. And so palliative care exists for children, exists for adults with cancer. It focuses on relieving symptoms and stresses of cancer. It's provided by a team. This team works together to provide an extra layer of support. And in contrast with hospice, it's provided right along with curative or disease-directed treatment. Next slide. And so just to emphasize, when I talk to patients and families, I say that we have expertise in 3 areas: symptom assessment and management, support for coping with cancer and the effects of treatment, and thirdly, what I would say, goals of care. We communicate to help make sure that all of someone's care is guided by their values and priorities. Next slide. So if you think about hospice and palliative care, they have the same features, characteristics, except one of these 4 items.
All right, and if you're using the texting, just a reminder that if you choose provide pain and symptom management, that'll be A. Support patients and families, B. Depend on a prognosis of less than 6 months to begin services would be C. And may be provided in home and nursing home would be D. Maybe take another 7 or 8 seconds. All right, Dr. Winzelberg, how are they doing?
Yeah, well, I may have worded the question in a confusing way. These are the way board exam questions for doctors look. The correct answer is C, as I'll talk about. Both services provide pain and symptom management, support families. D wouldn't have been a correct answer in the past, but palliative care, as we'll talk about, has moved into other areas. But it's that prognosis piece that really one of the main things that separates hospice and palliative care. Next slide. So this is sort of a compare and contrast with hospice on the left, palliative care on the right. And if you look, very, very similar in terms of pain and symptom management, how we support patients and families, the kind of communication that we have. There are some differences in terms of hospice really is its own comprehensive insurance benefit. I talked about covering equipment. Jenny will talk more about some of the supports. Palliative care is more limited in terms of insurance coverage. I would say the main thing which I bolded is palliative care can exist from the time of diagnosis of cancer or other serious illness, whereas hospice requires someone really to be at or towards the end of life. And then palliative care is provided currently in hospitals for the most part, although it's developing as Jenny and I practice in clinics, in homes, and in long-term care facilities, whereas hospice still primarily is in people's homes. Next slide.
Okay, so it's my turn. I'm hoping everyone can hear me. But I want to talk about the role of the nurse in palliative medicine. So, you know, nurses play a key role in delivering palliative care services to patients and families. LNAC is a national project that's sponsored by the American Association of Colleges of Nurses that offers palliative care training and education to a wide variety of nursing disciplines such as oncology, critical care, geriatrics, and pediatrics. But generally speaking, palliative care in nursing is centered in 6 areas. Expert symptom management skills, assessing symptoms such as pain and nausea, fatigue, sleeplessness, appetite challenges, depression, anxiety, bowel habits, and just overall functional ability is super important. Patients with serious and chronic illness often have multiple symptoms which require frequent check-ins and medication adjustments. So nurses can help assess and triage and offer education on managing those symptoms, and by coordinating with the provider, hoping to prevent emergency room visits and hospitalizations. Nurses can offer home visits or telephone support to accomplish this. So skipping down to communication support and facilitation, nurses help to create a space for patients and caregivers to communicate their goals, their wishes and values with each other and also their healthcare team. You know, communication can be very complex, and it's impacted by differences in health literacy levels, coping strategies, and language and cultural differences. Many patients have been known to feel more comfortable sharing information with their nurse rather than their doctor because of stigma or status. White coat syndrome, you'll notice that especially in our clinic, we try not to wear white coats because we know that that can off-put and make patients fearful of communicating with them. But nurses help facilitate open and supported communication. Care coordination. The healthcare system is very overwhelming, especially in cancer care. So some of you in the audience may have had a diagnosis of cancer and gone through treatment yourself, or have had a loved one that's been diagnosed and gone through treatment. There are many people involved in someone's cancer care team. Radiation doctors, chemotherapy doctors, surgeons, nurses, nurse practitioners, PAs, certified nursing assistants, physical and occupational therapists, specialty doctors like lung and bone, and in fact, there are so many people involved. Not only is it hard to keep up with who's who, but the multiple appointments, procedures, and medications can be very overwhelming. So nurses can help coordinate trying to make staying on top of these things manageable. Nurses can help coordinate the ever-changing interactions and patients' updates that amongst these plethora of people. Additionally, a patient may have a cancer treatment plan, let's say to start chemotherapy, all teed up and ready to go, but if that patient relies on a caregiver to take them to their appointment and their caregiver gets sick and the patient may not, say their car breaks down and they don't have the money to fix it because they have mounting debt, because they can't pay their medical bills, because they have income loss, because they have lost their job, because they have cancer. You see how we get right back to square one with those barriers. So nurses can help identify those barriers up front, like transportation difficulties, income loss, caregiver support or lack thereof, housing threats, with the goal to keep patients able to attend their appointments and treatments and ensure that they have access to critical medication. Fourth, psychosocial support. Nurses can help patients and families with anticipatory grief and loss and just overall coping support. Many cancer conditions are not curable, and many are, but sometimes cancer itself can't be fixed. Nurses can help create a space to support patients and caregivers with the emotional roller coaster that cancer often brings with it. From the time of diagnosis to the time in between appointments and scan results to end-of-life experiences. Helping patients maintain a sense of hope and even redefining hope, rethinking about hope. Maybe not, especially for patients with advanced illness, maybe not hoping for a cure, but hoping for well-managed symptoms with more time with family and friends and hope for even a peaceful death. And finally, helping patients think about and prepare for their future. This is called advanced care planning. You've probably heard the term getting your affairs in order. Well, this is part of advanced care planning. It's making and documenting decisions like identifying someone to be your healthcare decision maker, someone you trust to make those medical and health decisions for you in the event you are unable to do so. It also involves making decisions for you in the event that, or choosing certain life-prolonging treatments that you might choose in the event that you become seriously ill, like CPR, or being on a breathing machine, or dialysis, or external feeding mechanisms. It also involves identifying your wishes related to organ donation, burial, or cremation, and funeral arrangements. These can be very challenging things to think about, but a palliative medicine clinician can help create a safe space to talk about these things. Next slide. So we've already talked about the importance of care coordination as a central role for the palliative care nurse. I really like this graphic. I hope you can see it because I think it highlights the multiple services and components involved in helping patients and their families remain rooted in patient-centered care. Next slide. And finally, a little bit more about advanced care planning and some resources for you. This last slide, again, identifies some trusted, there's a lot of information out there on the web, but some trusted resources for more information about how to talk with your own families about advanced care planning a little bit easier. One of the phrases we often use in our clinic is that we hope for the best, but we prepare for the worst. In our clinic, we encourage patients to use the Prepare for Your Care document in helping to draft advanced directives. You can access it at the website there. The Conversation Kit, again, it's a website, offers great strategies on how to open that conversation with family and friends about advanced care planning. And finally, Vital Talk. Vital Talk offers a number of resources for patients and specifically healthcare professionals on how to deliver serious or bad news, how to discuss death and dying, and even how to have a family conference. Next slide.
Thank you. So I think hopefully this is helpful in terms of, again, thinking about how hospice and palliative care relate. All hospice is palliative care, but not all palliative care is hospice. And so comfort care is something that may happen sort of in the last hours of life in the hospital, generally with hospice care. Hospice is focused on the final weeks or months of life, but palliative care coexists with cancer and other disease treatments to really try to support quality of life in all of its dimensions. Next slide. And then even separate, and there are resources through the Cancer Network about this, survivorship as a even separate topic. Next slide. So again, as we're working towards summing up a little bit, here's a wonderful paper about the 10 things that palliative care clinicians wish everyone knew about palliative care. One is, again, and Jenny referred to this, that palliative care helps address the multidimensional, multifaceted aspects of care for someone facing a serious illness. That it's appropriate at any stage. Truly, we help care for people at or very close to the time of diagnosis. That for patients with cancer, and I'll talk a little bit more about outcomes, early integration of the services that Jenny and I provide is really becoming the standard of care. Separate from what we're able to talk about, but it is a service not just for patients with cancer, but for other chronic diseases, that we can manage what we call total pain, so not just physical symptoms, but suffering, other emotional components of people's experience. Next slide. That there are many symptoms, not just pain, that we help address, that we help support the emotional impact on patients and families. Jenny alluded to this with advanced care planning, but it also gets involved with talking about hospice, talking about discontinuing cancer treatments, that we can assist with that. That we really want to address the barriers, that the hopes and values that people have are more than hoping for a cure, particularly if that's not possible. And that there is increasing evidence that the role of palliative care helps improve the overall value of healthcare to our society. Next slide.
And one more thing to mention that I'm sure is demonstrated in the research is that patients and families involved in palliative medicine also decreased overall healthcare costs. And I think Dr. Winzelberg probably alluded to that, but that's a big one to administrators as well, because again, it loops back to preventing hospitalizations and ED visits and extra doctor visits as well. So let's consider which of the following patients, and I'm sorry for the typo, this is what happens when you've got a busy clinic and doing slides very quickly, could benefit from palliative care. So we have a 64-year-old with a stage 2 prostate cancer and congestive heart failure with high blood pressure and diabetes. A 32-year-old with acute myelogenous leukemia, or AML, 57-year-old with newly diagnosed stage 3 breast cancer, patient with 3 children and who is recently divorced, and a 76-year-old with chronic obstructive pulmonary disease, or COPD, and stage 3 lung cancer. So next slide. All of them. So from the time of diagnosis to end of life, all of these patients have varying degrees of needs and unique situations. The first patient, congestive heart failure, it's a chronic condition, and it requires, often patients with this disease often require frequent symptom check-ins, and unfortunately there are multiple hospitalizations for flare-ups. So definitely could be helped by a palliative medicine clinician and services. The leukemia patient is considered an AYA patient. And I mixed up the terms, but it's an adolescent and young adult. So those patients who are, I think it's 18 years old up to 40 years old, they have very specific, unique needs when they have a chronic or living with a serious or chronic illness that can be helped by a palliative clinician. The breast cancer patient, of course, has experienced recent and significant life change, including a cancer diagnosis, but even more importantly, the loss of a caregiver and a support person, and she'll still have those childcare needs to have to figure out how she's going to get through her treatment. And finally, the COPD patient, again, it's a chronic condition requiring frequent and multiple symptom check-ins, and again, often, unfortunately, results in multiple ED visits and hospitalizations, so can benefit from palliative medicine. Next slide.
So I think this may be our last question, but it is a preview of the next slides. Palliative care has been demonstrated in research studies to have all of the following outcomes except. So all A, B, C, D, 3 of them are true and 1 of them is not true.
And if you are doing this with the texting, just to emphasize you would select A, improve patients' quality of life, B, shorten patients' survival, C, increase length of hospice enrollment, or D, decrease use of chemotherapy within 60 days of death. So all of them except which one?
So the correct answer, as I'll talk about, is shorten patient survival. So one of the things that I would emphasize actually with both hospice and palliative care is that neither service in any studies has been shown to shorten how long people live. And there can be misunderstandings about that, but I think that's something that is an important take-home message. Next slide. So this is 10 years of research, and the citations are at the bottom, related to palliative care. So there have been more than 10 randomized trials specifically of cancer in the last 10 years looking at palliative care, where half the people got palliative care, half the people didn't. Individuals with advanced cancer, meaning metastatic to other parts of the body, lung, different parts of the gastrointestinal tract, so colon, pancreas, and then even in the setting of what's called a stem cell transplant for blood cancers. And what's been shown over these many trials is that there is clear benefit in improving patients' quality of life with standardized surveys measures. That involvement of palliative care not just improves quality of life, but reduces depression in patients who receive it and increase the overall satisfaction that patients have with their care. So that's with essentially all of those trials. In at least one of the trials or more, there have been other benefits. So there was a very influential study, now 10 years old, amazingly, showing that patients with lung cancer lived longer if they received palliative care than those who didn't. What I would say is that palliative care as a discipline has not been shown in all circumstances to lengthen life, but again, no evidence in any of these trials that it shortens life. There are other benefits. It can decrease use of chemotherapy in the weeks or few months before death, when patients are most likely to be harmed from it rather than benefit. Palliative care can be associated with longer hospice enrollment. I mentioned that slide at the beginning of how many patients only receive hospice for less than a week when it's nearly impossible to provide them the care that they need. And there's more discussion of prognosis and wishes with someone's oncologist, because palliative care is sort of helping support some of those discussions. Next slide. So a study that sort of synthesized all the data looked at the outcomes both in terms of patients and caregivers when it came to palliative care. And this was over 12,000 patients, almost 2,500 caregivers. Most of the studies were in cancer, but there were a few other disease groups, as you can see. And again, just to emphasize, there was improved quality of life for patients 1 to 3 months after receiving palliative care, improved symptom management, no association with survival in terms of either lengthening or shortening, and improvements, as Jenny alluded to, with advanced care planning, engagement, satisfaction of patients and their caregiver, and less utilization of services that weren't benefiting patients towards the end of their lives. Next slide. So I wanted to sum up with really a dear patient of mine who is really ever in my thoughts, NF, he was first diagnosed actually 3 years ago at age 47 with metastatic lung cancer. And I met him because he moved with his wife to North Carolina because he knew he was going to die from this cancer at some point, and her family was in the area. And I met him in our cancer hospital. And over the time after meeting him, I saw him in clinic, I saw him in the hospital supporting, and Jenny was integral with this in managing his symptoms, pain, bowel trouble, in conjunction with our cancer support program, depression, and all the while he was receiving cancer treatment. So he would see his oncologist, and at the same time he would see me. He actually went to another institution to get another opinion. We were with him along with that. Unfortunately, this year, he continued to have cancer progression, and we were, over time, along with symptom management, talking with him about what the goals were that he had with his life. And he ultimately, over the summer, developed a blockage in his intestine from the cancer that could not be managed, but he was quite symptomatic from it in terms of nausea and vomiting and pain. And his wife was not able, despite her love, to be a solo caregiver for him. And so he transitioned to that inpatient facility that I showed you the picture of. And actually, his wife was with him 24/7. He was able to have visits from his cat. And he survived for over a month, much of that time with very good symptom management and time with his wife. Next. And so in summary, palliative care and hospice are interrelated services that are components of what I would call this service continuum for patients with serious illness and their families. That hospice is primarily a home-based service at the end of life that is expanding, particularly in the inpatient hospice setting. That palliative care started in the hospital as a response to, hospice not meeting those patients' needs, but it's moving what we call upstream to the home, to the clinic, and that both services depend on teams and focus on improving patients' quality of life, the symptoms that they experience, and recognizing that their families are integral and also may need support as well. Thank you.
All right. Thank you, Dr. Winzelberg. Thank you, Jenny. We now have time for questions, so I want to encourage our audience to go ahead and submit their questions. And as soon as we receive any of those, we'll go ahead and pop those up on the screen. I'm just looking to see if any have come in. And while we're waiting to see if questions come in, let me ask both of you. We're assuming that most of our audience today, these are individuals who are already in healthcare programs at community colleges. And should they decide because of your presentation, maybe some of the other presentations in this series, that they would like to pursue a career specifically in oncology, what would be some of your suggestions in terms of next steps, either while in a community college program or beyond that time? Jenny, I'll start with you.
For folks who are interested in attaining a degree in nursing, I would say try to capitalize on those clinical rotations and preceptorship opportunities in clinical situations where the bulk of the patients might be oncology patients. And in terms of palliative medicine, I really want to stress that no matter what degree or discipline of nursing you go into, whether it's critical care, pediatrics, geriatrics, palliative medicine serves all of those patients. So you can get a specific training and certificate in palliative medicine nursing and integrate that into your nursing practice anywhere you go.
Great. Thank you so much. Dr. Winzelberg?
I think I would echo that in terms of in whatever, the opportunities in healthcare are, to my understanding, expanding, certainly in North Carolina. And so thinking about, clinical connections in whatever program someone's in and sort of gravitating towards oncology. And then once someone is there, asking about palliative care and trying to get exposure, because again, our work at UNC and increasingly even at other of the UNC affiliated hospitals are providing palliative care, but we're not in a separate building. We're right along with the other cancer providers, and so we tend to be a friendly bunch, and welcome opportunities to give others exposure to the work that we're doing.
Great, thank you so much. I'm going to. It looks like we don't have any questions in yet. I'm gonna stop by our question section again right at the end. I've seen both Jenny and Dr. Winzelberg in action. They are phenomenal and part of a phenomenal team. I should also mention that Gary leads a program of various palliative care lectures that are on our website, and I've heard the one that was most recently done on dignity is absolutely outstanding, as are lots of the others. So if you have an interest in this, certainly check those out.
And we have a question that was put on the chat, Tim, about other areas in addition to nursing, and can we speak to those opportunities?
That would be great. So outside of both of your disciplines, what are some of the others that a student might pursue specifically related to oncology?
And so to me, I think related to oncology, but even thinking about hospice and palliative care, nursing assistants, and there are sort of different titles. In inpatient hospice, for example, are a key member of the team. And so the care that they are providing to patients in inpatient hospice and home hospice is incredibly important. Pharmacy is another important role that individuals can have. And so whether it's formal training as a pharmacist, or if someone is in a long-term care facility in terms of being, med tech training, opportunities to help support those in long-term care facilities, I think there are opportunities there. In hospice and palliative care, there's less direct connection to therapy services, although certainly in palliative care, that's something that we're thinking about in terms of rehabilitation for those that are receiving cancer treatments. And so there is the opportunity for those who are interested in physical occupational therapy to have a particular focus on serving patients with cancer as well.
Absolutely. Physical therapists, occupational therapists, speech therapists, and social workers and chaplains.
Great. Thank you both. And we have a question that just showed up, and I'm having trouble popping it up on the screen here. But with COVID-19, how has cancer care changed or improved in terms of hospice care?
Oh, well, I'll start. I mean, and I'm speaking from the perspective of palliative care, not oncology. I think from the palliative care perspective, the ability to do virtual visits, I think, has been very helpful for patients who, would otherwise have to travel long distances to see us. And so we've been able to sort of make those connections and provide care that patients otherwise wouldn't receive. What I would say in terms of oncology, and I would defer to the oncologists themselves to discuss, but I think it's changing, and certainly UNC has been outstanding in terms of universal masking and physical distancing, but there has been concern, and our cancer center has produced some videos about this, that people aren't going to get the necessary care that they need, whether in prevention or in treatment, because of concerns or fears that they have. And so that's been something that our oncologists have really had to work to support patients in, coming to the office, coming to get treatment. And so that's an ongoing concern, that the pandemic is affecting the care that patients are receiving.
All right. Thank you. Jenny, anything you'd like to add to that?
Not too much.
Okay. All right. Well, we should wrap up. We're over time. I appreciate our audience for hanging in there. I just want to say a few things as we wrap up. First off, thank you to each and every one of you who have attended today. Please know how much we appreciate your participation, and it's wonderful. As I mentioned, there are lots of other lectures recorded in this series, and then we've got lectures coming up as well. University Cancer Research Fund, we really appreciate the North Carolina General Assembly and their generous support of the University Cancer Research Fund, which makes this possible. The UNC Lineberger Comprehensive Cancer Center, thank you to them. Thank you to Mary King, Veneranda Obore, John Powell, Anita Woodyard, for all of their hard work for each and every one of the lectures in this series. Thank you to Lori Bird and to Kathy Davis with the North Carolina Community College System for all that they do to make this series possible.